So lots to do. We have 100 slides, which includes previous year questions also of ENT as well as pediatrics. So that is what. Yeah, Zara. I'll bring Zara. Sometime in the middle. She's just woken. She's just woken up, and I was trying to bring her, but she's very cranky. She didn't want to wake up, so she was very cranky. If I bring her, she would be like constantly crying on your faces, and she would take me along. So I think it's better we don't bring her now. So we'll bring her sometime in the end of the class. Okay, hopefully if she's free. Okay, so shall we begin then? PDF I've already posted. Saurabh, you can just join the group. You will ask for link, won't you? I'll share. You want to see Ravi sir also? Why do you want to see my entire family? Um, I just share the link of the group. Okay. Here. So I pinned the message here. Uh, 8 seconds, just setting the AC. Okay. Thank you. Thank you for wishing, Zara. All right. So let's begin then. हाँ हाँ यार ये तो है like this is the best time no to sleep. She sleeps so peacefully, like babies sleep without any sort of stress. That is motivation. No one knew that you also want to sleep like a baby, isn't it? So you want to be done with NEET PG. Isn't that the biggest motivation ki khatam ho, this should get over, right? And you can sleep like a baby. Even though in residency you can't, like you will then wish for this period ki yaar yehi kitna acha time tha. You could just study, you could sit and study whole day, so it's basically going to be that always you would wish for the prior life. Like when you are in MBBS, you would wish na ki residency jaldi shuru ho jaye, PG jaldi ho jaye. When you start for PG preparation, you're like yaar MBBS kitna acha tha. When you go into residency, you'll be like yaar wo PG padhne ka period kitna acha tha. When we all we had to do was just sit and study. There's no stress, there's nothing. Then when you complete your residency, you would get married, you would have kids. Then लगेगा यार residency में कितना सही था कि no stress, no responsibilities, and it will be so on and so forth. I don't know, there will come a time someday, I'm still waiting for it, when it'll be like, okay, now I have everything which I want and I'm not wishing for anything in the past. So that is how I'm still waiting for that time, but it never really comes. I think we just keep wishing for things in the past, and in the present we keep having a distorted sort of a notion, right, of things that we want. So that is something that I think the problem is in our mindset, right? So the moral of the story, I think, through all of our common feelings, is that you just have to be happy and live in the present, no matter what it is, right? So whatever time you have right now, you might wish for it to end, but it is something that you will cherish someday, right? So yeah, be grateful, have gratitude, and make the most of it. So enjoy this process. And so this is also something where, do you think ever again in life you will get to study 19 subjects? You'll never ever get to do that, right? So this is why we became doctors, to study medical science in general. And believe me, it doesn't really, it's not like you are studying rest of the subjects just for nothing. It is always going to come up some way or the other. So some patient will come to you, or some relative will ask for advice, and what if you already know the answer, and you are able to help them? There's no feeling like that feeling, isn't it? So basically try and study for that rather than for the exam. Study it for the medical science and enjoy the process. That is why we took this in the first place, isn't it? To study, isn't it? So enjoy this. And yeah, so that is what you have to do. So life lesson देने की कोशिश नहीं कर रही, but this is what I have also learned, कि हमारा normal tendency is to crib about things, but when you just look thoda sa away from yourself, you would actually realize that you are much luckier than a lot of other people, and other people would want to be in your place where you are, actually cribbing. So that is something that you always have to realize, that you are blessed and privileged, and count your privilege, basically. So that is what is very important. Okay, with that, let's go into ENT. So we had done ENT ka ear, outside ear, right? So now we go to inner ear and anatomy. God, we are starting having such positive vibes. We are now going into ear anatomy. What, like, cut to ear anatomy from this positivity. Okay, so here, yeah, I do practice radiology. So now I'm not getting to, like, I'm not going anywhere because I don't have the time, but I want to resume soon once Zara grows up a bit. I'm doing telerad at the moment, but I obviously want to practice it. हाँ, so चलो, तो ये हमारा tympanic membrane है, right? So now first of all, right versus left, we will get to it, but all of you recognize this is tympanic membrane. All of you have heard umbo, right? So this is the malleus which is projecting through it. तो ये umbo हो गया, and umbo से this is the cone of light. When we look at the cone of light, we can get to know whether it's right or left, right? So depending on this, so this basically falls on the antero-inferior quadrant. So through this handle, I'm gonna divide the tympanic membrane into anterosuperior, anteroinferior, posterior-superior, posterior-inferior quadrant, right? And anteroinferior quadrant is the most important. Why is it the most important? One, it has the cone of light. Second, this is the site where I'm going to do what? If I want to do myringotomy, right? If I want to drain the middle ear, I can do this. If I want to put in a grommet, I'm going to put in through this only. What is the only indication of putting in a grommet? A tube, a ventilation tube? Yeah, it is serous otitis media, right? Anytime we have fluid glue ear that we had studied yesterday, that is the only time I want to put in a grommet. I do not want to put it in CSOM or nothing. Increasing volume, is that a problem for anybody else, Neha? I think it's normal only, like always. Just try and adjust your volume. I think or wear headphones probably. Okay. And apart from that, what else? This is also the site which gets affected in trauma, right? So traumatic perforation also, you're gonna have this site which is affected. So this is why it's important. Now, how to know right or left? So there's a good question that they can make. So we just have to see ki cone of light which o'clock pe hai. So if it is at 5 o'clock position, 5 comes first, and right, we always say right left, right comes first. So 5 o'clock position is right, and when it is at 7 o'clock, you see how it's at 7 o'clock position. So when you see that this is at 7 o'clock, this is the left tympanic membrane, right? So this is a question that they can ask you कि बताओ ये right ear है या left ear है. So this is how we will get. Yeah, 7 you can invert left. That's also a good trick to remember. Okay, cool. Now I'm showing you 3 appearances of tympanic membranes, and we'll make the diagnosis. So with this pink sort of a mass, I'm also giving the history that there's pulsatile tinnitus. Correct. So whenever there's a pinkish mass in pulsatile tinnitus, only one differential, which is glomus jugulo-tympanicum, right? So this is in the jugular fossa as well as going into tympanic cavity. So we call it glomus jugulo-tympanicum. The other differential, not with this appearance, but just in general, when you see pulsatile tinnitus, one more anatomical variation which you have to keep in mind is what? Yes, all right, that's a different thing, but I'll tell you. Yeah, so that is an aberrant or a persistent stapedial artery. Normally stapedial artery, an artery of which pharyngeal arch? Second arch artery, right? So second aata hai sab kuch. So second arch artery usually regresses, but when it's persistent, it will course within the ear, stapedial. So it course within the middle ear, and that time also you can actually feel the pulsation. It's pulsatile tinnitus ka second lesser known differential. Now, glomus of finger. So that is something which is a nail bed tumor, a completely different from this. Very vascular, but it's something which occurs in the nail bed, and it has a lot of pain, right? So it will be a very painful vascular tumor which you will have. Yeah, excruciating pain करके बोलेंगे जब you press on it. All right. So this is about that glomus. Coming back to ear. So a few signs about glomus jugulo-tympanicum that you need to know. Whenever we do the MRI, so this is the jugular fossa here. This is the medulla. This is the cerebellum. Here near the jugular fossa, we have this tumor which is enhancing on the MRI. This is a contrast enhanced MRI. That is what we do for all tumors, isn't it? We want to give contrast. So I've given contrast, and do you see how there are some black spots, kuch white spots here. So that is why this is given the name of salt and pepper. Yeah, so this is called as salt and pepper sign. Okay, so this is called salt and pepper sign. So this is the first sign that we have. First sign that we have for glomus. What are the other physical examination sign? When you see this red colored mass, yeah, even Jogren shows you salt and pepper, correct? ऐसा जब मास मिलेगा, sunset close enough, rising sun, right? So sunrise हो गया, sunset नहीं. So this is rising sun sign. When you see this pinkish mass, when you apply pressure on it, it will blanch because it's vascular. उसको क्या sign बोलते हैं? That is called as brown sign. So this is called as brown sign when it blanches on applying pressure. If you do CT, you will see that the keraticojugular spine the crest between carotid and jugular is eroded. Yeah, so that is the CT sign that you will see, which is called as Phelps sign, which is the erosion of the jugular crest or spine. All right, so these are the sign liख दिया spine. All right, so these are the signs that you will have as far as glomus jugulotympanicum is concerned. All right, which are important. Second tympanic membrane appearance, when you have painful vesicles and erosions over the tympanic membrane, what is the diagnosis? Yeah, one more point that Anu has said, we use a staging which is called as fish staging for glomus. Yeah, that also you can remember here. This is not cartwheel, these are painful vesicles. Cartwheel will be seen in ASOM, right? So cartwheel is seen in early OSOM when you have a lot of erythema. But right now I am having vesicles and bullae. Correct. So this is called as bullous meningitis, right? So this is called as bullous meningitis. Iski cause pe nobody is able to still narrow down. Some people say that it is viral in nature. Some people say that it's caused by mycoplasma. Some people say it's bacterial. So nobody really knows the cause. Yeah, you can have multifocal also, one also. Yeah, ऐसा कुछ नहीं है. This is bullous meningitis. Basically, you'll have painful vesicles. That will be the word that they will use here. Okay, so this is about the second appearance. Third appearance, something that we've already seen. When you see कि ऐसा bluish hue आ रहा है, पानी आ रहा है अंदर से. So this is your serous otitis media. So when you see serous otitis media in an elderly patient, 50-year-old, has nodal masses in the neck, what do you want to suspect? You want to suspect NPCA, because remember torus tubaris, that was getting blocked by this mass here, yeah, fossa of Rosenmuller say, and then it was blocking and causing serous otitis media. Similarly, if you see this in a young child, you want to think of adenoids, right? So this was the approach that we had thought of. To manage this, we have to do myringotomy and we have to put this, which is grommet. So this can come as an image-based question. This is how a grommet is going to appear. Again, which quadrant? Do you see this? Light के पास ही आ रहा है बिल्कुल. So antero inferior quadrant में अपन ने डाल दिया. What year is this patient affected? Right or left? What is this year? 7 o'clock, right? 7 को उल्टा कर दिया, left ear. Very nice. This is also left ear, है ना? Same patient. Okay. Now going on to the anatomy of middle ear cleft. Okay, so middle ear में we have three parts. Yeah, so जो tympanic membrane है उसके ऊपर का part is epitympanum. Tympanic membrane wala part is mesotympanum and this is hypotympanum. Okay, yeah, grommet is removed. When is grommet removed? Approximately in how many days do we remove grommet? Have we no clock? You know clock? 5 o'clock, 7 o'clock, like that, Anamika? है ना? तो if this is clock, this is 12, this is 6, this is 3, this is 9, 5 and 7, like that, है ना? Yeah, so it is removed in 3 months. Yeah, so 3 months is when we remove. Okay. Yeah, all right. So this is about epi, meso and hypotympanum. Okay, so now what are the diameters here? Which is the widest, which is the narrowest? Remember 6, 2 and 4. 4 plus 2 equals 6. ऐसे करके आना है. ठीक है. So hypo is 4. This is 2 and this is 6. So 4 plus 2 equals 6. ऐसा करके हम लिखेंगे. Alright. So narrowest is going to be mesotympanum. Widest is going to be epitympanum because that is where we have everything, right? I have most of the ossicles there. So remember that is where you have the widest diameter. Can I see the same picture on CT? First of all, remember for entire temporal bone, what is the investigation of choice? It is going to be HRCT. So for ENT, remember PNS के लिए भी HRCT, temporal bone also HRCT. So this is lateral. Can you see ये थोड़ा थोड़ा पिन्ना दिख रहा है आधा कटा हुआ? And this is medial. This is a coronal image. All right. So this is coronal image where this is lateral, this is medial, this is upper, this is niche. So again, do you get the same orientation? This is where our tympanic membrane. This is going to be epitympanum. This is meso, and ये छोटा सा is hypotympanum. Okay, ये वाला is parts of inner ear. This is middle ear, and this is your eustachian. This is your external auditory canal. Okay, now what I wanted you to notice here was, yes, do you see this bone? Yeah, do you see this bone in front of epitympanum? Yeah, this bone is called scutum. इसको बोलते हैं scutum. Just hold that thought before that. Let's just imagine this now. Okay, so this is the tympanic membrane. This is malleus, this is incus, and this is stapes. So tell me, what is this space called between tympanic membrane and malleus? This space is called, very nice, this is called as the Prusak's space. Why am I stressing on this? What is the importance of Prusak space? So Prusak space is where you're gonna have cholesteatoma occurring earliest, है ना? तो Prusak space पे सबसे पहले आता है cholesteatoma, isn't it? So what will happen when Prusak space has cholesteatoma in the epitympanum? Look at this. Now look at this CT image. अगर epitympanum, this is where you will have Prusak space. If there is cholesteatoma here, do you agree that this bone will be eroded? Scutum will be eroded? Yeah. So actually a very early sign of cholesteatoma or CSOM that we can pick up on the CT is scutum erosion. So this is the earliest sign of CSOM. Did you guys understand this now? ये line पड़ी होगी, but now did you understand with the help of image कि अच्छा ये है scutum, तो यहाँ पे अगर आएगा Prusak space में तो it will definitely erode on this bone, right? So that is what scutum is and that is what cholesteatoma is. All right, very nice. Okay, now let's do a few pointers about ear ossicles. So you all recognize malleus, incus and stapes. Yeah, what is the joint between malleus and incus formed? What is that joint basically between malleus and incus? That is the saddle joint, right? So remember, इसमें S नहीं आता MNI में, so that starts with saddle. On the other hand, what is the joint between incus and stapes? Incudostapedial is ball and socket. So remember, जहाँ पे S आ जाता है stapes का, वहाँ पे S नहीं आएगा. So don't confuse the two. Second thing, what structure goes here on the incudomalleal joint? Which nerve, if I can ask you? So here you have chorda tympani. So second thing, एक तो type of joints हो गया. Second, which structure lies here? It is chorda tympani. Two more questions. Which is the site which is affected the first by otosclerosis? Otosclerosis में क्या affect होगा? Foot plate of stapes, right? So this area earliest to be affected in otosclerosis or most common basically. If I ask you which is the most common site or the earliest site to be eroded in by necrosis in cholesteatoma, अगर necrosis हो रहा है, which part of incus? Not neck, lenticular process. So now which is the lenticular process? It is here, right? So एक छोटा सा process जो यहाँ पे आ रहा है, that is your LP. That is the site which is affected by ischemia most commonly. So remember, ischemic necrosis or basically just necrosis by cholesteatoma, it is going to be this site. Okay, so this is the lenticular process. So quickly just to show you the shapes, because last NEET mein they just showed you malleus and asked to identify it. Okay, so malleus, this is the main handle which we were seeing as umbo also. So sorry, incus, which is the long process, right? This is the malleus here. Sorry, this is long process, is short process, and this is the malleus, which is going to have the manubrium. Yeah, it was incus which was shown. Fine. So incus you have to identify on the basis of long process, short process, and then there's this very tiny lenticular process. Incus, on the other hand, will have a complex structure with a manubrium, lateral process, head, all right, and then stapes to koi puchega nahi. Okay, so that is how you can identify. Yeah, actually it tends to look like a T, right? Incus tends to look like T a bit. Okay, so that is how you can actually identify them. All right, so this is about the ear ossicles. हाँ मतलब अभी now don't make this mistake, it's okay. All right, so malleus, incus, stapes. Now going on to this, I'm sure you have seen this image a lot of times in your life. Do you want to go, do you really want to study middle ear anatomy? Right, so middle ear anatomy, remember, because they will not ask you this. अभी मैं आपको orientation दे रही हूँ, what they are going to ask is going to be something completely different. For that, this orientation needs to be there. Okay, this is the most basic thing, right? So we'll just do a quick revision and then we'll go into the real stuff. Okay, so whenever we're talking about middle ear, all right, so just think of it as a box first of all. या कमरा सोचो या बॉक्स सोचो. तो सबसे पहले कौन सी दीवार हटा दी हमने, which is the lateral margin. So just look at this image, this will give you the orientation. This is our dabba, right? So remember here our lateral margin, isn't it? So this is going to be lateral. Lateral हो गया tympanic membrane. Medial हो गया this which is facing the inner ear. Anterior हो गया आगे, posterior हो गया पीछे. So floor and roof, I'm sure you understand. So remember, anterior नहीं हटा दी, lateral हटा दी, है ना? So tympanic membrane हटा दी. So what I see सामने is medial, this is anterior, this is posterior, roof and floor. Orientation समझ में आ गया? Now, first thing, सबसे easy कर लेते हैं पहले. Roof and floor we have no doubt, है ना? तो roof पे क्या है? We have the tegmen tympani. What question can come here? Tegmen tympani, you have one prominence which is called arcuate eminence. So tell me, arcuate eminence is produced by a bulge from what? Obviously रूफ पे है तो कौन सा semicircular canal होगा? Superior, right? So this is formed by superior semicircular canal, which gives you this bulge, which is arcuate eminence. And if you're coming from above, this is called as middle cranial fossa approach. If you are entering the middle ear through the brain, right, by lifting the meninges and brain, we are not going through brain, we are lifting and then entering from upper. That is called as simple middle cranial fossa approach. So roof is tegment tympani. Understood? Floor में क्या है? Internal jugular vein. Not important. Now going on to anterior and posterior. तो anterior पे क्या है? The mnemonic here is T. That is what I remember. T. तो सबसे ऊपर क्या है? You have tensor tympani, right? So you have tensor tympani which is entering into the ear. We will see that it has some part on the medial side also, but this is tensor tympani. E से क्या है? Eustachian tube. Remember glue ear वाला eustachian tube. And नीचे क्या है? A से artery, internal carotid artery. So these are the three things that you have. Tensor tympani जा रहा है, eustachian tube जा रहा है और आगे एक artery है. Very simple. And this artery will eventually reach the floor also. So far so good. We have one छोटू सा एक और canal जहां से कौन जा रहा है? Chorda tympani. So it's arising from the posterior wall and then it's going and coming here. In between, did we see कि वो incardomalial के बीच में जा रहा था? Right? So that is how it is going. Okay. Now tell me something. What is this canal called? Very nice. So this is called as canal of Eugier. All right. So this is called as canal of Eugier, through which the chorda tympani is going to go. So in addition to T, we have one canal of Eugier also, through which chorda tympani exits. So far so good. Everybody, 2, 3, 4. 4 walls done. Now we go on to the medial wall. ठीक है, जो हमें दिख रहा है. When I enter the ear through by opening tympanic membrane, this is what I see. So here, what do I see in the medial part? First, wherever you have this tegment tensor tympani which is going, you have one hook-like process which attaches it and then it goes to the handle of manubrium. ये क्या है? A और P. ठीक है, तो इसको क्या बोलते हैं? Yes, this is called as PC. Processus cochleoformis. So this is a hook-like projection जहां से tensor tympani cross करेगा and will attach to the malleus. Okay, so this is first thing. Second thing, do we all see two windows? We all know about them. This is the oval window जहां पे क्या लगा हुआ है? Stapes का foot plate. What is this? उसके नीचे round window where you have a membrane, right? Membranous labyrinth के contact में है. So these are your two windows, oval window and round window. Easy peasy. Then what do you have here? There is one nerve which is coming. What is this nerve? This is the facial nerve which is first coursing on the medial wall and then going on to the posterior wall and going down. है ना? तो facial nerve, is it open here or is it in a bony canal? It is in a bony canal here, right? So what is the name of the canal? This is called as fallopian canal, right? So it is within a bony canal called fallopian canal. Uske upar, we have one sinus. What is this semicircular canal? So this is your lateral semicircular canal. What question can come here? So this is the most common site for what? This is the most common site for fistula to occur, right? So if there is going to be a perilabyrinthine fistula, this is where it occurs most commonly. So एक और question हो गया. Most common site of perilabyrinthine fistula, lateral semicircular canal. Superior से क्या देखा था? ऊपर, arcuate eminence. All right, ये याद रखोगे. Lateral हो गया medial wall पे. Remember, lateral semicircular canal on the medial wall. And finally, we have this. What is this? This is your bulge. This is your bulge, which is promontory, and promontory is formed by what? This is formed by basal turn of cochlea. ठीक है? So medial wall पे what are all the structures? We have one processus cochleoformis, hook-like projection. Then we have oval window, round window. We have facial nerve. We have lateral semicircular canal, and we have promontory. So far so good. Everybody, is this clear? You need to know the structures. Easy है ये, इतना मुश्किल नहीं है ना? Once you get the orientation, you won't forget. Now, one wall is only left. See, we have almost done. Only one wall left, which is the posterior wall. So posterior wall किसके connection में है? Here you have मेस्टॉइड, राइट? सो इसके जस्ट बगल वाले कमरे में कौन रहता है? इसके साथ वाले कमरे में रहता है मेस्टॉइड, isn't it? So here we have one खिड़की, we have one window. So what is this? So this is, yeah, this is the tympanic plexus here. So here we have one खिड़की which is your adductus to mastoid antrum. Okay, so here we have communication. So remember, posterior wall के साथ में लगता हुआ mastoid antrum है. Fine. Then what else do you have? We know already that we have the facial nerve, which is going to give a branch, all right, which is going to give a branch, which is chorda tympani, which will run between incurdomalleal joint and then exit through the anterior wall. So this is the junction, right? In addition, what do we have? We have a pyramidal eminence, which gives rise to stapedius, right? So this is the stapedius muscle, which is going to insert on the stapes. Now, just imagine like this. So this is the wall, right? And I'm looking from here. The surgeon has entered from here. Do you agree that when I go medial to the facial nerve, let's imagine this is the wall and facial nerve is here. So medial to the facial nerve will be a hidden area. Can you imagine this? कि यहाँ पे अगर facial nerve है, this area is quite hidden, isn't it? When I'm seeing from here, कि ये side का शायद नहीं दिखेगा. So what is this area called, which is the hidden area? Correct. So this is called as sinus tympani or facial recess. What is the medial area? Sinus tympani, right? So this is the sinus tympani, which is the hidden area where you will have residual cholesteatoma. So because the surgeon cannot see medial here, that area is sinus tympani, and that is where. So one word I want you to write here, that sinus tympani. So if this is the facial nerve, medial to it, ST, and because it is hidden, this is the most common site for residual as well as recurrent cholesteatoma. Understood? तो ये मीडियल है इसलिए छुपा हुआ है. फाइन. ऑन द अदर हैंड उसके लेटरल कौन है? फेशियल रिसेस. सो लेटरली वी हैव फेशियल रिसेस, मीडियली वी हैव दिस, राइट? सो वी राइट ऐसा श्रीमती लिखते हैं, ऐसा श्रीमती, श्रीमान, लाइक दैट. एसएमटी, यू कैन रिमेंबर एसएमटी गो टुगेदर, राइट? सो साइनस टिम्पनी इज medial, whereas facial recess is lateral. So what is the use of facial recess, which is lateral to this? The facial recess ka use hai when I want to enter middle ear from mastoid. We know this is where mastoid lives, isn't it? So if I want to enter via mastoid, can I use this facial recess? Yeah. So this is called as posterior tympanotomy. Posterior wall है, posterior wall से निकल के आ रहा है. So this is posterior tympanotomy, जहां से हम facial recess से enter करते हैं into middle ear. Understood this, everybody? Yeah. So now, if this is understood, we are gonna invert this. अचानक से दुनिया flip हो गई. So now just see this. This is, everybody got this orientation, right? That this is medial wall, this is posterior wall. Now let's make this ulta. So if I say that this is where stapes is attached to the oval window, does this make, what is this wall then? नीचे कौन सी wall होएगी if this is where stapes is attached? Will it be posterior? No, we already saw, right, कि oval window, round window कहाँ आ रहा है? Medial wall पे. So now I have just flipped this room such that this has become my medial wall. ये कौन सा wall हो गया? This is my posterior wall, right? So we are just seeing it in a different orientation. So you all recognize this. This is the pyramid, right? Pyramidal evidence. This is the stapedius. This is the seventh nerve, and this is chorda tympani. So now, if they ask me to label this, is it very easy? I just have to see कि medial वाला recess कौन सा है. So when they ask me medial recess, I know my mnemonic, which is SMT. So medial is gonna be sinus tympani, lateral is gonna be facial recess. Yes. So this is your one previous year question done. Does it seem so easy now? अरे खाली medial lateral ही तो देखना था. So once you get this orientation, then it's very easy. वरना समझ ही नहीं आएगा कि चल क्या रहा है. Right? So once you get this orientation, so KK, basically we know that stapes attaches to the oval window. Yeah. So now you have to just imagine that this medial wall has gone down. It has gone down. है ना? तो ये नीचे चला गया. So only you have to just write one thing, that this is medial. The moment you write this medial, then you know that there are two recesses here in the posterior wall. The medial recess is sinus tympani, where you have cholesteatoma, which is retained, and lateral recess is facial recess through which the surgeon will enter through posterior tympanotomy. Okay, first difficult image done. More difficult image. So now we are going straight. अब हम zoom करके जा रहे हैं into the posterior wall. Okay, now we are going into the posterior wall. So again, do you recognize stapes? Yeah, so this must be oval window, right? अरे अभी भूमि ये सब stress नहीं, अभी focus here. When you are studying, nothing else should cross your mind. Now you are into ear, into posterior wall. अभी डरमा कहाँ से याद आ गया? Okay, so this is stapes, right? This is pyramidal eminence with your wall. Now here, Now we are going straight into sinus tympani. All right, we are into sinus tympani, the medial part, and two bony ridges I want you to identify. In this recess, जो ऊपर का part है is P. P for ponticulus. And नीचे वाला recess क्या है? नीचे वाला bone क्या है? Subiculum. So I have two bones which are forming the boundaries of sinus tympani, right? So this is this is ponticulus and this is subiculum, and this is your round window. And can you see this promontory? So we are just zooming into the medial wall, right? So this is the medial wall that you have. ये promontory हो गया, यहाँ पे oval window है, यहाँ पे round window है. So just zooming into sinus tympani again. Can you see the facial nerve? Horizontal part, vertical part. Here you have the sinus tympani. All right. Medial lateral नहीं, ऊपर नीचे. So ponticulus is ऊपर, subiculum is नीचे. All right, that is what you need to know. Medial lateral is not a reference here, right? So now same thing when we see via endoscopy. See this via endoscopy. Okay, so again, you are seeing incus stapes, which is attaching here to the medial wall. Okay. Now again, if I mark that this is sinus tympani, can you all recognize this bone which is ponticulus, this bone which is subiculum, and in between you have the sinus tympani. PS is called as posterior sinus. So apart from the sinus tympani and facial recess, you have one more recess which is called as posterior sinus that you are seeing. Okay, right versus left कैसे इसमें क्यों पता करना है, right? No, don't focus on what I'm telling. Okay, so this is what you need to know. So they can ask you, they can label any structure here and they can ask you. So they can ask you sinus tympani, uske upar ponticulum, uske niche sinus tympani. PR is promontory. What is PE? P is pyramidal eminence, where which is attaching, right? So this is your pyramid here attaching to the stapes. This is incus, all right, and this is the facial nerve which is going down. Okay, so will you identify the structures on this image? Did you get the orientation here? Yes, round window. RW is round window. So oval window, niche round window. Okay, just see this again. All right, if you are not understanding this, again see one more time. Purana wala model dekho and then you will get it. Okay, so this is about the endoscopy image. Now, if this was clear, I hope most of you this is clear. Yeah, so now we are looking at posterior wall. So अब हमारा middle ear is done, but now I am going into the posterior part. Remember the adjacent room we had ignored कि अच्छा यहाँ पे mastoid रहता है, तो अब हम उस room में जा रहे हैं. All right, so this is that room which is your mastoid, which is posterior. Yeah, it is more posterior to the middle ear, बाजू वाला कमरा. So this is the posterior wall. This is the anterior wall, and posterior wall में है mastoid air cells. All right, so I have removed the air cells. So what do I find? I find that there is one sinus. What is this sinus which we are seeing here? Oval window you won't see, no Satya. Will you see oval window? Stapes है ना oval window पे. तो यहाँ पे oval window तो दिखेगा ही नहीं, उसके ऊपर stapes है, right? So this is sigmoid sinus. What is this? Roof remains constant, right? Tegment tympani is same. So what is this? Here you have roof, so you have dura. So this is called dural plate. And this where you have sinus, this bone is called sinus plate. So do you remember the Law's view? Where we were seeing mastoid air cells, we were seeing two bony ridges. Yeah. So what was this sinodural angle? Sittelis angle. Now is it making sense that when mastoid is pneumatized, this angle would be normal, but when it is sclerosed, air hi nahi rahi, this would become acute. Are you guys understanding this now? So this angle between these two walls is called as the Sittelis angle or sinodural angle. So remember sigmoid sinus in relation here. Okay, तो अब ये कॉमन दीवार पे जाए. व्हाट इज दिस कॉमन दीवार which is communicating via adductus ad antrum? This is your posterior wall, isn't it? So now let's zoom into the things here. Okay, so what was the area through which I was trying to enter into the middle ear via the mastoid air cells? Facial recess, right? I want to come via the facial recess. So where is the facial recess? So this is my vertical part of what nerve? Vertical part of facial nerve in the posterior wall. And what is this? This is the chorda tympani, right? So this area is where I'm going to drill and I'm going to enter via the facial recess. A few boundaries that you need to know. One very important canal. What is this now? What sinus is this that you are seeing here? Sorry. Huh? Yeah, so this is the lateral semicircular canal, right? So this is the lateral semicircular canal that you are seeing as a bulge here that we had seen on the medial wall also, right? So this is the lateral semicircular canal. So this is how we have imagined in our head. अभी तक समझ में आ गया सबको that हम यहाँ से आ रहे हैं. Sinus tympani तो अब उस तरफ चला गया, right? Sinus tympani is more medial. अब हमें lateral side से हम देख रहे हैं. Okay, fine. So this is where we are coming from, the lateral aspect. Now patient is not going to come like this. When we do a surgery, patient letega, isn't it? Patient will lie down. So what will happen to this? Now, do you agree when patient lies down, the mastoid goes down? Yeah. So I'm just going to flip this image because that is how intra-op we are going to see. So up kya ho gaya? Again to orient you. Sigmoid sinus. This is the tegment tympani, dural plate. This is sinus tip. This is your Sitelli's angle. सबको समझ में आ गया? उल्टा कर दिया हमने patient को. Now what do we have? This is my facial nerve. This is chorda tympani. So is this the recess that I'm going to create? Yeah. So recess ke just saath mein we have lateral semicircular canal and we will have incus also. Okay. So now let's see the exact image. This is going to be just like this. So this hole here is what? This is the facial recess jahan pe maine hole kiya. Before that, can you get the orientation? Sigmoid sinus. Sigmoid sinus. What is this? This is dural plate. So Sitelli's angle कहाँ आया? ये समझ में आ रहा है orientation. So this is Sitelli's angle. अब now look at this. So this nerve that you are seeing here is the facial nerve. Can you see this facial nerve here? This is the facial nerve. And what is this branch? This is, what is this arrow showing? ये छोटा सा nerve जो जा रहा है यहाँ से. What is this? Correct. Wonderful. This is chorda tympani. This is facial nerve and the area that I have drilled is my facial recess. अंडरस्टूड. एंड यहाँ पे एक बल्ज आ रहा है. दिस वाज द एग्जाम क्वेश्चन कि ये जो बल्ज है वो क्या है. सो दैट बल्ज इज माय लेटरल सेमीसर्कुलर कैनाल जो मुझे यहाँ पे दिख रहा था. डिड यू गाइस अंडरस्टैंड? सेम फेशियल नर्व, कॉर्डा टिम्पनी, फेशियल रिसेस, लेटरल सेमीसर्कुलर कैनाल एंड एक जो बोन दिख रहा है यहाँ से दैट इज इनकस. Yeah. So that is, this is the toughest image that you will get in the exam, and what has come in the past is labeling lateral semicircular canal. I is incus. So incus bhi yahan se dikhega actually. Okay. So this is what was there, which I took a lot of time to study and simplify. अब समझ में आ गया. एक बार और देखना पड़ेगा, but mostly समझ में आया, right? So just do it one more time and you will hopefully understand. Okay. So this is what it is. ST, sinus tympani, Kirti, is on the other side of this, right? So that is all happening more medial. हम lateral है, समझ में आ रहा है? Okay, so that is what you have to do. Okay, good. I'm just happy that most of you could understand. Okay, तो अब हम जा रहे हैं into 4 accuses, है ना? 4 accuses में जा रहे हैं. So just अब exam questions पे जाते हैं फटाफट. Alright, 37 minutes, अब बहुत कुछ करना है. 80 slides in the next 1 hour. Let's do it. Presbycusis is age-related hearing loss, right? High frequency, low frequency, high frequency, right? Hyperacusis क्या है? Hyperacusis is when you don't have stapedial reflex, and as stapedial reflex चला जाएगा तो you'll hear very loud sounds, right? तो वो inhibition नहीं हो पाएगा. Diplocusis क्या है? You will hear double sound at the same frequency. This is a feature of what? Which disease? Diplocusis. Correct. This is a feature of Meniere's disease. Paracusis villi. What is paracusis? That you like to be in noisy surroundings, right? The patient hears better in noisy surroundings, and this is seen in where? This is seen in otosclerosis. So will you not confuse all of these accuses? है ना? इसलिए same slide पे रखा. Just see them once. Do not confuse them. Now let's interpret all the audiograms which are there. First of all, इसमें right versus left कैसे बताएंगे? Same. They haven't made it tough for us. Red माने right, left माने blue. So raw से red, right? So whenever you see red, it is right. Whenever you see blue, it is left. So that is the first thing. Then 2 basic things. Whenever you see a gap, right? So there is a gap here. Whenever you see air bone gap, so this is air and this is bone, right? So remember cross जहाँ पे है, this is your air और ये वाला bone है. So whenever you see an air bone gap which is more than 20 decibels, that is conductive hearing loss. Whenever they go down together, that is sensory neural hearing loss. Okay, so that is the first basic thing I'm sure all of you know. Now there are only 4 graphs that we need to know. We'll make it very simple. Whenever you see कि bone conduction में 2000 hertz पे drop आ गया, What is this called? दो notches. एक हो गया 2000 का notch. इसको बोलते हैं Carhart's notch. Where do you see Carhart's notch? Which is a notch, a dip at 20,000 hertz of what? Of bone conduction. This is seen in otosclerosis. So otosclerosis has conductive hearing loss or sensory neural hearing loss. Obviously, airborne gap hai. It is going to be bilateral, gradually progressive conductive hearing loss. Remember that. Now, if I have a dip at 4,000, you see, दोनों ही dip हो गया. This is called as Boiler's notch, right? Boiler's notch बोलते हैं. So where do you see this? Correct. This is seen in noise-induced hearing loss. What frequency? Double. 4,000 hertz. So when you see 4,000 hertz पे जा रहा है, high frequency loss, noise induced hearing loss. One question about noise induced hearing loss. कौन से cell को ये affect करता है? Inner hair cell, outer hair cell. It's going to be inner hair cell, right? Is it outer? Wait, not just. No, it is going to be inner hair cell, right? So confusing है थोड़ा सा. It's going to be inner hair cell. If there is gap, it's normal. It can be normal also, but you see it's dipping, right? अगर normal हुआ तो 20 decibel तक आएगा. Is that controversy? हाँ, controversy है क्या? चलो देख लेना. मतलब that is what I had read कि inner hair cell है. Have you read outer? चलो ये देख लेना. तो आई एम जस्ट नॉट राइटिंग इट, विल जस्ट डिसाइड ऑन द ग्रुप. ओके, व्हाई गेट इनटू कंट्रोवर्सी, बट आई सॉ अ रिपीट क्वेश्चन वेयर इट वाज गिवन इनर हेयर से. आज ही मैंने देखा. ठीक है, आउटर 100%. just clarify है ना. So it's controversial, so we'll just see, right? I don't want to solve these controversies. Okay, so this is gonna be Boiler's notch, noise induced hearing loss. हाँ, तो देख लेंगे एक बार, कंफ्यूजन देख लेना है ना. तो अलग अलग जगह बताया होगा. जो मैंने जहां से पढ़ा वहां पे इट वाज मेंशन्ड इनर, इसलिए मैंने चेक भी किया. एनीवेज, सो टू कर्व्स. ऑलराइट, सो ये एक बार देख लेंगे, बट दो नॉचेस याद हो गए. नाउ वी गोइंग टू टू कर्व्स. व्हेन वी सी दैट कर्व इज फॉलिंग, मतलब देयर इज हाई फ्रीक्वेंसी हियरिंग लॉस. सो व्हाट डिड वी सी? presbycusis. Again you see कि कोई gap नहीं है, right? So this is sensory neural hearing loss which is occurring at high frequency. So that is presbycusis. On the other hand, when you see कि यहाँ से शुरू हो रहा है, right? So it's a rising sort of curve. So there are low frequencies which are affected first. So this is early Meniere's. Remember, later on में सब same हो जाएगा, but early Meniere's में you're gonna have low frequency hearing loss first. Okay, so that is what you need to remember about two curves. Down sloping तो presbycusis, ऊपर चढ़ता हुआ तो Meniere's. बस ये चार करने हैं. Now these four diseases very quickly. Before that, just one. Middle range में dip हुआ. What is this called? This is called as cookie cutter graph. तो cookie cutter graph किस में मिलेगा? बताओ. Good. This is seen in कू से cookie, कू से congenital, right? So कू से कू baby. This is congenital hearing loss, right? So congenital sensory neural hearing loss is going to be seen because of various anomalies. So just you need to know two anomalies. ये कौन सा anomaly है? I'm giving you two options. एक है Michel's aplasia, एक है Mondini's dysplasia. गुड. तो मिशेल के तो नाम में ही है ना, अप्लेजिया. शुड आई सी एनी सॉर्ट ऑफ इनर ईयर हियर? ये हमारा मिडल हो गया, तो उसके मिडल हो गया इनर, तो इनर तो दिखना ही नहीं चाहिए. व्हेन आई सी इनर ईयर इट कांट बी मिशेल, राइट? सो मिशेल अप्लेजिया इज कंप्लीट एब्सेंट इनर ईयर क्लेफ्ट. When it is dysplastic, that is called as Mondini's dysplasia. So what happens in Mondini's dysplasia? Yes, your 2.5 or 2/3 turns are not happening. They are going to be 1.5 turns, and you're going to see that the apex is very cystic. पूरा apex cystic हो जाता है. So this is what I'm going to find. Normally when I see the CT, so I'll show you the normal first. Don't need to go into the details, but when we look at the cochlea, this is the cochlea. Does it look like a flower? It's going to have this central modulus, and then it forms this flower like pattern. क्योंकि scala, vestibula, tympani और ये सब है ना, तो it's going to look like flower. All right. So when I don't see that flower, that is how we recognize as radiologists कि flower नहीं दिख रहा, modulus is not there. That is how we recognize Mondini's dysplasia. Okay, now why am I teaching you such hi-fi stuff? Two questions. Cookie bite and cookie cutter, same. हाँ, same. Cookie. All right. Cochlear implant. Tell me, when we talk about cochlear implant, what is the absolute CI of CI? Contraindication of cochlear implant. Obviously, we can't do it when ear ही नहीं है ना. तो Michel's aplasia is a contraindication of cochlear implant. What is the other contraindication of CI? CI of CI? is when you don't have the nerve, right? When eighth cranial nerve is absent, तो भी नहीं कर सकते. So those are absolute contraindication. What about Mondini's? Is that a contraindication? No, it is not a contraindication to CI. No, not CI to CI. Okay, so this is something that we see. Flower again, yes. So just look at the HRCT. So this kala kala is middle ear, isn't it? This is middle ear. This is inner ear. So inner ear mein these are your semicircular canals which are meeting here at the vestibule. This is internal auditory canal which is going into cochlea. So your vestibulocochlear nerve and everything is attached to the cochlea here. So when we look at the cochlea, it will have this flower sort of an appearance. There will be a central bone and then there are these two membranes which are dividing this into the three cavities, isn't it? So this is how cochlea normally appears. When you see कि ये कुछ दिख ही नहीं रहा, inner structure bone नहीं है, flower नहीं है, कुछ नहीं है, because it's a completely cystic sort of a cavity here in Mondini's. So I won't see the finer structure. Okay, so this is how this appears normally. So this is normal inner ear. On the other hand, just one thing, ice cream cone appearance. Do you see this? So this is the incudomalleal joint. This is a joint between incus and malleus, which is called as an ice cream cone appearance, which is again normal. One more ice cream cone I'm going to see in vestibular schwannoma. ठीक है, जो मैं आपको दिखाऊंगी. Right? So this is going to be ice cream cone. Fine. Now just flashcards. Quickly we will diagnose 4 to 5 diseases. Young female है bilateral gradual, conductive or SNHL, CHL, right? So this is conductive hearing loss. One clue they will give, aggravates in pregnancy. So bilateral conductive hearing loss, gradually progressive, aggravates in pregnancy. Paracusis villi, we already know that loud background में बड़ा मजा, पार्टी में जाएंगी हमेशा ये female. Why? क्योंकि उनको better सुनाई दे रहा है, right? So in loud and noisy backgrounds, they hear better, isn't it? Impedance tympanogram is something which is what we are going to do for all conductive hearing loss, है ना? So conductive hearing loss में हमें हमेशा एक tympanogram करना है. So all graphs quickly अपने को पता होना चाहिए. What is type A? A is normal, है ना? So this is how normally when I go from this pressure, तो -100 to +100 में this is how it normally behaves. So this is what eustachian tube is going to behave when we give pressure, positive pressure, negative pressure. Okay, इसके detail में नहीं जाएंगे, just नाम सुनेंगे. Type A is normal. Where do you see type AD? D for dislocation or discontinuation. So this is seen in ossicular discontinuation, right? Or dislocation, whatever. AS, छोटा छोटा ग्राफ, सो से otosclerosis, right? So this is what is seen in otosclerosis. Type B, do you see how B is flat? Whenever we have fluid, air fluid level is horizontal, this graph is also horizontal. So B matlab pani. So this is seen where? This is seen in serous otitis media. And type C, eustachian tube में C आता है. So this is when you have eustachian tube which is blocked. Anytime ET tube is blocked, what will happen to tympanic membrane? It will be retracted, right? So this can also be seen in retracted tympanic membrane. ठीक है, तो ये वाला सही कर लोगे, whatever is the graph. तो otosclerosis में कौन सा मिल रहा है? AS. ठीक है, very easy. What is Van der Hoof syndrome? Then association where you have osteogenesis imperfecta, correct, which has blue sclera with otosclerosis. So OS plus OI is Van der Hoof syndrome. What is the treatment of otosclerosis? ET tube function, tympanogram is investigation of choice. Yes, I am not sure. Just check. Treatment is going to be stepidotomy because we have not done many diseases about that, right? So stepidotomy or stapedectomy, right? So this is the treatment of choice and you would put a stapes prosthesis, right? But if you see that there is something called as Schwartz sign, wherein you are going to have this salmon pink color or flamingo pink color, which is there on the tympanic membrane, not salmon, but yeah, flamingo is the perfect word if it makes any sort of difference. So flamingo pink color aa raha hai tympanic membrane mein, then it is an indication of giving sodium fluoride. Then medical treatment can be tried because it's an active disease. Okay, so this is the Schwartz sign. CT पे क्या दिखेगा? So suddenly you will see that around the inner ear you would find that there is this halo, right? So this is also called as halo or target or double ring sign. So when you see this in CSF rhinorrhea, it is traumatic CSF rhinorrhea. When you see halo target double sign on the CT, it is something which is this, okay, which is sclerosis. Okay, sodium fluoride can reverse this disease. Okay, yeah, so this is seen in cochlear otosclerosis, which is pretty rare. Okay, all right. So halo is because of the bone, right? So the spongiform bone is what we are seeing here. ठीक है, बस इतना सा याद रख लो, बहुत है. So this is about otosclerosis. Next disease, identify. Just details of surgery, please refer to specialist. Yes, this is presbycusis. Okay, so this is presbycusis. So here you're going to have old patient, bilateral. We saw that sloping down, sloping curve, high frequency sensory neural hearing loss. Very good. Then when you see upsloping, what is the diagnosis? This is Meniere's. Meniere's will present with what? TVS. So here you will have all three. So TVS, you will have tinnitus, vertigo, sensory neural hearing loss. So this is going to be unilateral and episodic. All right. दो phenomenon टॉसे Tullius phenomenon. Anytime they go into loud background, loud noisy, what will they have? They will not like it. Auto wali female was enjoying. These patients will not enjoy because they will have vertigo. Loud sound पे vertigo हो जाएगा और loud sound पे क्या हो जाएगा? गिर जाएंगे. They will fall. They will have ataxia. These are called as drop attacks, right? So this is Tumarkin's phenomenon. So these guys don't like noisy background. घर पे रहेंगे आराम से. Okay, so this is that. Diplacusis, दो sound नजर आएंगे, सुनाई देंगे. What is the investigation of choice for Meniere's? What am I showing you? They can ask you what is, identify this technique. Correct. So whenever you see summating potential, action potential, this is इलेक्ट्रोकॉक्लियोग्राफी, है ना. तो आइडेंटिफाई करने को बोल सकते हैं. सो इलेक्ट्रोकॉक्लियोग्राफी, यू विल सी these graphs with summating and action potential. That is the investigation of choice for Meniere's. How do you treat Meniere's? So diagnosis पता चल गया. Yeah, the ratio is more than 30%, right? So dip in low frequency, right? So low frequency में पहले affect होगा and eventually everything will be affected, right? So first is just dietary changes. So low salt diet, caffeine, like all good things in life हटा दो. Caffeine, chocolate, alcohol and tobacco हटा दो, उसकी जिंदगी से ठीक हो जाएगी, right? So what is this? So this is this is where most patients will respond कि अच्छा अच्छी चीजें चली गई जीवन से, I will respond. So most patients will respond to conservative treatment only. If it doesn't respond, 3 से 6 महीने हटा दो सब कुछ. Acute attacks फिर भी आ रहे हैं, so you can give diuretics or just steroids or antihistaminics and stuff. Now comes the exam question. फिर भी treatment failure हुआ तो what is the device we can use? See this. So this is called as Minute डिवाइस. सो मिनट डिवाइस क्या है? उसमें हम एक प्रेशर देते हैं, पॉजिटिव प्रेशर देते हैं. सो दिस इज व्हाट इट लुक्स लाइक. सो इमेज बेस्ड क्वेश्चन कैन कम, राइट. सो उससे कुछ कुछ होता है. प्रेशर देंगे तो ना वो the fluid, basically the balance, the height drops reduces basically on the round window when we give pressure through the middle ear. ठीक है, ये कर दिया, कुछ भी कर दिया, still it is not responding. So what do we decide to do? We decide to kill ear. इतना ओटोटॉक्सिक ड्रग दे देंगे थ्रू माइक्रोविक. सो व्हाट इज दिस डिवाइस? इमेज बेस्ड क्वेश्चन वेयर वी आर पुटिंग अ डिवाइस इनटू द इनर ईयर एंड आई एम इंजेक्टिंग जेंटामाइसिन. सो दिस इज कॉल्ड एज किसका माइक्रोविक? Silverstein's microvic. All right, so this is Silverstein microvic procedure where I am going to inject gentamicin into the ear and I will kill it. ना रहेगा ear, ना रहेगा Meniere's, right? तो ये हमने कर दिया. If this also fails, तो हम finally जाएंगे surgery में. All right. Meniere's device is a pressure device where I'm going to generate some positive pressure in the middle ear. That pressure, no, basically will move this fluid around in the inner ear, in the labyrinth, and that will basically respond. वो acute attacks में हम कर देते हैं. Okay, so this is what we are doing. Yeah, must be anterior inferior only. What do you see here? Just one line that you want to know, that this is the line, Donaldson's line, that I use to enter into the ear. All right, so this is the अगर labyrinth तक पहुंचना है, which line do you use? Donaldson's line. बस इतना सा याद रखो. Fine. So these are all the things about and yeah, these are all the things about Meniere's. Okay. What is this? This we had seen in peds also very quickly. जो screening के लिए use करते हैं, auto acoustic emission, right? So this is the screening test for hearing. Is this done in everybody or only high risk? This is done in everybody, right? कौन से कब करना है? This is done at day 1 of birth. First day पे सबको करना है. Everybody gets this screening. On the other hand, what is this? Correct. This is confirmatory. So this is what is BERA device, right? So this is your BERA, brainstem evoked response audiometry. This is not BAHA, this is BERA. All right. So yes, this is both are objective. OE is also objective, BERA is also objective. Okay, so BERA is the confirmatory test. So if you find abnormal autoacoustic emission, we have to do BERA by 3 months. Remember. So the difference is, वो सब इम्पोर्टेंट नहीं था पार्ट एक्चुअली, वो सब पढ़ते हैं हम इन ईएनटी में जब हम बहुत डिटेल में जाते हैं, बट समहाउ इट नेवर केम इन एनी क्वेश्चन. सो क्वेश्चन मैंने केस वाइज कर दिया सो दैट इट्स इजियर फॉर यू टू रिवाइज फॉर एग्जाम्स. ओके, तो बस जितना करा उतना ही काफी है, बट वंस यू जस्ट सी एंड जस्ट एड इट. ओके राइट, सो बेरा इज कंफर्मेटरी एंड बाकी मैं क्या बोल रही थी, सी yeah, so this is where you are actually, yeah, so 1 month, correct. So one day पे हमने ये कर लिया. By 3 months you want to do BERA in everybody who has 3 months is the upper limit, कि तब तक BERA करके find out करना ही है, confirm करना ही है whether hearing loss is there or not. And by 6 months you want to treat. Okay, अगर 6 months तक आपने congenital hearing loss treat नहीं किया, then the person will start to have deficit, language deficit आ जाएगा, because 6 months is when they start to babble and all, right? So language deficits नहीं चाहिए, तो what is the timeline? You have to treat by 6 months. So remember 1 day, 3 months and 6 months. Okay, BERA में हमेशा पूछते हैं which is the most important wave. So there are these 7 waves which are seen. Wave 5 is most important. किससे बनती है wave 5? So for this you want to remember E. colima. E. colima was the mnemonic, right? So first 2 waves are because of 8th cranial nerve, proximal and distal. C is because of what? What is C? C is your cochlear nucleus. O is what? Superior olivatory nucleus. L is what? Lateral lemniscus. I is what? So L is your, this is your 5th, right? I is inferior colliculus. M is medial geniculate body, and this is your auditory cortex. So this is your entire auditory pathway. I'm sure all of you guys know this. So 5th is lateral lemniscus, right? 1, 2, 3, 4, 5. So this is your 5th, है ना? 6, 7. समझ में आ गया? So remember E. colima, and that explains the auditory pathway, which has been asked a lot of times, and that also tells you कि 5th wave is because of lateral lemniscus. And पूछे कि सबसे reliable waves क्या है, तो 1, 3 and 5. So 1, 3, 5 are the most reliable. 5 is the best one, which is because of LL. Okay, सबको समझ आ गया? E. colima नहीं भूलना. Okay, so this is BERA. What is this technique? दिस इज वेम्प. 8 भी हो सकती है, 7, मतलब सबसे 5 इंपॉर्टेंट है. वेम्प का फुल फॉर्म बताओ. This is vestibular evoked myogenic potential. Just one question here. What is it testing? It is testing the function of what? WEMP. It is testing the function of saccule. It is testing the function of saccule. हाँ, sternocleido में लगाते जरूर है, but it's eventually testing saccule का function. Alright, so this is what we can do for balance and vertigo issues. Then look at this. This is when you have dehiscence. Can you see how your superior semicircular canal की wall is deficient? So this is called as semicircular canal dehiscence. One question only. SCC dehiscence has SNHL or CHL? Asked in a lot of exams. Correct. This has conductive hearing loss, right? So ये बात याद रखो that this has CHL, not SNHL. Okay? Bas. What is this? Another ice cream cone. So this is the pons. MRI दिखा रही हूँ. This is cerebellum pons. This is at the CP angle. Now one of you in your marrow GT was saying ki ma'am, this is invading. This looks like it's invading into pons. Remember, this will never invade into pons, right? So this is something which is arising only from the pons. So this is your normal CP angle जहाँ से हमारा 8th cochlear nerve, I mean vestibulocochlear nerve and 7th nerve is arising. So here you are gonna have the tumor which is forming. So here in the CP angle there is room. So वहां पे ice cream बन जाएगा. And in the internal auditory canal there is no room. So it forms this narrow cone. है ना? So this is your CP angle tumor. Most common CP angle tumor, ice cream cone appearance, vestibular schwannoma. Arises from which nerve most commonly? Arises from the inferior vestibular nerve most commonly. Investigation of choice, CE MRI. Histopath, you will see Antony A, Antony B areas. So your cellular areas are your Antony A areas, which show you what? They show you these bodies, which are your Verrucay bodies, and the acellular area is going to be Antony B, which is your myxoid stroma. Very very important. ये path में हमेशा सवाल आएगा. Sign of all schwannomas. Treatment of choice. Remember, first is going to be surgery. ये सब palisading यहाँ पे नहीं है. ओके हाँ, तो ट्रीटमेंट बता रही हूँ ना, ट्रीटमेंट ऑफ चॉइस इज सर्जरी, बट अगर इनरिजेक्टेबल ट्यूमर है, राइट, सो इट वी आर सीइंग अ वेरी लार्ज ट्यूमर, व्हेन इट्स अनरिजेक्टेबल देन वी गो फॉर गामा नाइफ. Okay, so first line is always going to be surgery, but a very recent advance that we do in a lot of unresectable cases, very advanced big tumors that the surgeons don't want to open, gamma knife. Understood? So this is about vestibular schwannoma. Diagnosis? Yeah, gadolinium is MRI contrast, है ना? Benign paroxysmal positional vertigo. So this is the diagnostic maneuver. दो चीजें पूछ सकते हैं. So जब आपको दिखता है कि दो चीजें हैं, सीधा खड़ा रहा and then हमने 45 डिग्रीज कर दिया, लेटा दिया, this is diagnostic. This is your Dix Haplick maneuver, right? So this is इससे भी पता चल रहा है डायग्नोस्टिक. थेराप्यूटिक क्या है? जब बहुत कुछ कर रहे हैं, पहले सीधा, फिर उल्टा 45 डिग्री, फिर उल्टा 45 डिग्री, फिर लेटा के खड़ा करा. दिस इज योर एप्लीज maneuver. So in your PDF you can read this entire Epley's maneuver. This is from Dhingra. Okay, so ये पढ़ लो, है ना? तो बहुत सारा है. तो Epley थेराप्यूटिक, जब खाली दो चीजें कर रहे हैं, डायग्नोस्टिक. ठीक है, ओके. Epley का प्रोसीजर पढ़ना है, चलो पढ़ो फिर क्या क्या कर रहे हैं. So basically problem क्या है? Here we have an otolith which is stuck in the posterior semicircular canal. तो उसको निकालना है किसी तरह. तो क्या क्या करेंगे? ठीक है, मुझे लगा मैरो वाले एकदम ही क्वेश्चन ऐसे पूछते हैं which I am teaching. Okay, so we have patient which is sitting facing forward. फिर हमने क्या किया? Patient is lying down in Dix Haplick position. Actually I can't read because ये मेरा ऊपर आ रहा है. Now the patient is lying down with the head hanging and turned 45 degree to the right. उसके बाद left कर दिया, उसके बाद दोनों को ऊपर कर दिया. You are turning both head and body as a unit to the unaffected side और फिर बिठा दिया with head bent 40. ये बस पढ़ लो ना एक बार, इसमें क्या टाइम वेस्ट. Let's just read this and you will know the sequence. Okay, so this is BP PV. You need to know this. All right, this is important. ये ऐसा नहीं है कि मैरो ने crazy पूछा. This is important. Okay, right. Now going on to hearing aids. INICT very favorite. So you have all of these kinds of hearing aids. Okay, right. So this is behind the ear. दिख ही रहा है BT. तो इसका full form पूछेंगे. They'll give BT. They'll BT क्या है? Behind the ear. ये क्या है? In the ear. ITE. फिर ओपन फिट नॉट वेरी इंपॉर्टेंट. सो बिहाइंड द ईयर, इन द ईयर. देन दूसरा क्या है? केनाल में चला गया, इन द केनाल. CIC क्या है? कंप्लीटली इन द केनाल. बस ये चार पता होना चाहिए. ठीक है, अभी सब लोग अपना गॉसिप बाद में करो. बिहाइंड द ईयर, इन द केनाल, कंप्लीटली इन द केनाल. व्हाट इज दिस? यहाँ पे कहाँ है हियरिंग इम्प्लांट? दिस इज अटैच, नो, दिस इज अटैच टू द बोन. सो दिस इज बाहा. कोई जो पहले बाहा बोल रहा था, सो दिस इज व्हाट इज बाहा. सो बोन एंकर्ड हियरिंग एड. तो इसमें हमने मेस्टॉइड में एक लगा दिया, एंड देन यू हैव दिस conductor link, and then you have this in the middle ear जो float कर रहा है. So this is your bone anchored hearing aid. When is this used? बाहा कहाँ पे यूज किया? सो दिस इज यूज व्हेन यू हैव नो केनाल, है ना? बाकी चीजें तो केनाल से ट्रांसमिट कर रही थी, इन द ईयर, आउटसाइड द ईयर, कंप्लीटली इन द केनाल. सो हियर व्हेन यू हैव EAC abnormality, या तो EAC का स्टेनोसिस हो गया, where EAC is absent, or when you have pus, right? So when you have discharge from the EAC. So whenever EAC is abnormal, we want to use BAHA. What is this? Now you have an implant which is actually stimulating the incus. Incus में जाके हमने vibration दिया सीधा. What is this? This is called as warp. So this can be asked as an image-based question. So vibrating ossicular prosthesis implant. So this is where सीधा ossicle incus पे attach कर दिया. This vibrating and stimulating it directly in cases of conductive hearing losses. तो ये तो सारे ही CHL के हैं, right? On the other hand, when you have sensory neural hearing loss, सेंसरी मतलब इनर ईयर में प्रॉब्लम है. व्हेन इनर ईयर इज एट फॉल्ट, व्हाट डू वी यूज? वी यूज कॉक्लियर इम्प्लांट. But when neural problem hai, we can't use cochlear implant. When eighth cranial nerve is at fault, what can we do? Now we have to do auditory brainstem implant, right? So now we have to use a brainstem implant. Where do we place brainstem implant is the question. We place it in the lateral recess of fourth ventricle. Very very important. So fourth ventricle के lateral recess पे auditory brainstem implants are placed. Okay, understood? So this is the treatment. Shall we go quickly into head and neck spaces? Oh, we have 63 slides, 65 slides to do in 30 minutes. Okay, head and neck space is not important. बहुत ही ऐसे फालतू है. So here what you have is you have superficial fascia and you have, नहीं मैं एकदम इजी कर दूंगी. We have deep फेशिया, राइट. सो सुपरफिशियल है, डीप सर्वाइकल फेशिया. डीप सर्वाइकल फेशिया को फर्दर डिवाइड किया इन सुपरफिशियल, मिडल एंड डीप. ठीक है, तो अल्टीमेटली डीप सर्वाइकल फेशिया के 3 लेयर है, सुपरफिशियल, मिडिल एंड डीप. दे आस्क यू कि बताओ कौन सी स्पेस किससे इंक्लोज हो रही है. सो वेरी इजी. सो सुपरफिशियल, मिडल एंड डीप. सबसे पहले, so these are all parts of what? Deep cervical fascia, right? There is one space which is outlined by all 3 of these fascia. वो कौन सी है जो तीनों में ही आएगी, जहाँ पे सब जा रहा है? इंटरनल कैरोटिड, इंटरनल जुगुलर वेन, sympathetic plexus, vagus nerve. कौन है? Carotid space. So carotid space is getting enclosed by all of them. ठीक है. फिर डीप मतलब एकदम सेंटर में, what must be here? So this is the perivertebral space. So perivertebral space is enclosed by the deep cervical fascia. बस काम खत्म. Middle is enclosed by this throat. So your visceral space or your mucosal space is enclosed by what? Middle cervical fascia. बाकी सारा is by superficial. So और क्या है? Carotid space हो गया. Then you have the parotid space which is enclosed by this. You have what else? You have the masticator space which is enclosed by this, and you also have the strap muscles which are enclosed by this, right? So everything else is enclosed by the superficial layer. बहुत थियोरेटिकल लग रहा है. लेट्स सी. सो जो भी येलो से आउटलाइन हो रहा है, येलो इज योर सुपरफिशियल लेयर ऑफ डीप सर्वाइकल फेशिया. तो ये कौन सा स्पेस हो गया? वेयर यू हैव योर pterygoid muscles, you have the masticator muscles, temporalis muscle. This is your masticator space. Yes, are you seeing how it's outlined by yellow superficial? ठीक है. What is this gland जिसको डिवाइड करते हैं superficial and deep via retromandibular vein, internal external carotid? Yeah, axial cut, no, obviously. So this is parotid space. Yeah, so this is parotid space, again outlined by yellow superficial layer. Then what else? The strap muscles also. Do you see the strap muscles? Sternocleidomastoid, peripherally yellow. बाकी कौन सा स्पेस है जिसमें तीनों कलर्स मिलेंगे? कैरोटिड. So this is your carotid space is also getting yellow. तो येलो का काम हो गया. Now let's look at purple, middle layer. कहाँ से हुआ है? So this is your mucosal space where you have the entire pharynx, nasopharynx, nasopharynx, oropharynx, laryngopharynx. That is outlined by the middle layer and also carotid space. Deep layer क्या है? Blue. Can you see how in blue you have this entire perivertebral space, vertebra and everything around it? That is your deep layer. Okay. हाँ, माइलोहायोइड मसल भी करता है. ओके, so वो सर्जिकल लैंडमार्क है बेसिकली. सो दीज आर योर 3 लेयर्स एंड द 3 स्पेसेस. इजी ना? सो स्ट्रैप मसल्स येलो, सुपरफिशियल लेयर. मिडल वाला येलो, कैरोटिड स्पेस ऑल 3, पेरीवर्टिब्रल स्पेस बाय डीप लेयर. ठीक है, डन. सो दीज आर द स्पेसेस. अब जाते हैं जो इंपॉर्टेंट पार्ट है यहाँ पे. इन द पेरीवर्टिब्रल स्पेस वी हैव फर्दर 3 बाइफर्केशंस. ओके, सो सबसे पहले जो फैरिंग्स है उससे अराइज होता है बक्कोफैरिंजियल फेशिया, इंटीरियर मोस्ट. देन वी हैव द एलर फेशिया and then I have the prevertebral fascia. So there are 3 fascia and now I'm going to have 3 independent spaces. So between buccopharyngeal and alar, what is this space? What is this space called? This is the retropharyngeal, behind the pharynx है ना. So this is retropharyngeal space. Very nice. Retropharyngeal space is divided into 2, right and left. It's divided into 2 by the fascia of Gillette spaces बोलते हैं इसको. ठीक है, तो वो right and left में divide करता है. So do you agree anytime I have a retropharyngeal abscess it would be unilateral, either right or left? या जहाँ पे nodes of Ranvier भी होते हैं, right? So this is gonna be unilateral. सबसे पहला yellow. Red में क्या है? Red. So this is danger space between alar fascia and prevertebral fascia. And prevertebral के पीछे कौन सा है? Prevertebral space. So 3 spaces हो गई. Craniocaudally सबसे जो आगे है yellow, retropharyngeal space extends till what inferior level? It extends up to tracheal bifurcation. Trachea के bifurcation. So somewhere around T4, right? So T4, T5 tracheal bifurcation तक. Đ से danger, Đ से diaphragm reaches up to the diaphragm. And finally, the prevertebral space that will extend till what? That will extend till way down, नीचे तक, coccyx तक जाएगा. ठीक है? So this is going to extend completely inferiorly. So these are your spaces. Okay. Now quickly you want to do infections. Yeah. So यहाँ पे क्या आएगा? Basically, if you see a prevertebral abscess, prevertebral thickening मिला, तो can I say lateral पे कि कौन सा involved है? Yes. If I see the inferior extent, If it's reaching till T4 bifurcation, it is retropharyngeal abscess. If I see that it's reaching up to diaphragm, it is danger space abscess. If I see it's going way down, it is your prevertebral abscess. Okay. The other way of saying, आगे से देखो, if it's unilateral, then it is retropharyngeal. If it's extending throughout, no laterality, then it is your prevertebral or danger space abscess. Understood? So this is about this. Now more infections. When I find this history, fever hai, can't eat, drooling, trismus, and I see this ring enhancing abscess, tonsils make abscess ho gaya. What is this? This is peritonsillar abscess or quinsy, right? So quinsy pe kya milega? I will see that the uvula is shifted, isn't it? How do you drain quinsy? दो lines बनाओ. Line along anterior fascial pillar and line through the base of uvula. Base of uvula से line बनाओ. जहाँ पे जो point है वहाँ पे needle डालो and drain it. So treatment is incision and drainage. Understood? Similar sounding name. When you see कि uvula का edema है, उसको क्या बोलते हैं? This is called as Quincke's edema. Alright, so that you don't confuse, Quincke's edema is when you have uvula ka edema associated with what? Associated with angioneurotic edema, hereditary angioneurotic edema. Uvula का एक और sign बताओ. The only other thing that you need to know about uvula. What is that sign when uvula is ऐसे rotate कर रहा है, pulsating uvula, correct? When is it seen? Aortic regurgitation. Sign का नाम बताओ. Not Demosis, that is called a Muller's sign. Muller's sign. Alright, so Muller's sign is when you have pulsating uvula in AR. तो समझ में आ रहा है कैसे पढ़ाई करनी है, right? So uvula पढ़ा तो uvula का साथ साथ रिवाइज करो. अब खोला ही है म्यूलर साइन तो साथ साथ सारी साइंस ऑफ एआर रिवाइज करो. दैट इज हाउ यू हैव टू स्टडी एंड दैट इज हाउ यू ब्रिंग ऑल 19 सब्जेक्ट्स टुगेदर बिफोर द एग्जाम. ऐसे नहीं कि पहले मैं खाली ईएनटी फिर मैं खाली ये, ऐसे नहीं करना. कभी भी कुछ भी मिले तो साथ साथ कोरिलेट करके आपको ऐड करना है. ओके वैसे करके अभी डी मिसेज पढ़ के आना. सो दिस इज क्विंकीज एडिमा, दिस इज म्यूलर साइन, दैट्स हेड बॉबिंग आई थिंक. एनीवेज, if you have similar history, same history in fact, fever, odynophagia, drooling, trismus, you're also seeing a mass here. But now I have this. What is this? Whenever you see that neck may be mass. So along with that, when you have a neck mass, this is your parapharyngeal space abscess. Are you understanding the pattern approach? Same history, same abscess. But when you have a neck swelling, it becomes parapharyngeal abscess from quinsy. All right. On the other hand, you have same history, but floor of mouth is affected. Double tongue sign. दो tongue है इसकी. It is Ludwig's angina. All right. So this is Ludwig's angina, floor of mouth, polymicrobial infection. Okay. On the other hand, if you find something like this, where now there is a thickening, soft tissue thickening, you are seeing air foci here. So this is retropharyngeal or parapharyngeal. बता सकते, sorry, retropharyngeal or prevertebral. Can I say on the basis of this? Can't really say, right? Can't really say, but more likely to be retropharyngeal because it is showing this kind of a margin. All right. So बता नहीं सकते, बहुत मुश्किल है, but you can see if it's unilateral or bilateral. So both of these are your possibilities. दोनों option में नहीं होंगे. Okay. So can you see how retropharyngeal is going to be basically right versus left? These are your nodes of Ranvier. Okay. Yes. The normal prevertebral thickness C2 पे 7 mm, C7 पे 22. So this is the mnemonic, number mnemonic. Okay. Fine. So this is about that. So now the trick is how to identify. Very, very important. ENT abscess. Contralateral displacement of tonsil मिला, दो options है. If I see swelling of sternocleidomastoid, it is what? It is parapharyngeal space abscess. Very important. If I see that there is no swelling, then it is what? Then it is quinsy. X-ray पे prevertebral swelling है. If I find that it is unilateral, it is RP, retropharyngeal. If I find it is midline, then it is prevertebral swelling, prevertebral abscess. If you have understood this, you have understood all ENT things. Okay? हाँ, lateral view पर नहीं बता सकते, Aditi. That was the whole point. Okay? One syndrome, when you have IJV thrombosis, you have septic emboli, and you have any sort of a retropharyngeal abscess. So retropharyngeal abscess है, IJV thrombosis हो गया उसके कारण, thrombophlebitis हो गया, and that is going into the lungs as septic emboli. What is this syndrome called? Correct. This is called as Lemierre's syndrome. All right. So this is called as Lemierre's syndrome. Normally, I would tell you 5 other confusing L syndromes, but I will let it go because we have lots to do. Okay, so this is Lemierre's. Vocal cord palsy, quickly you have to revise. Huh? So vocal cord palsy, basically it's all to do with vagus nerve. So vagus nerve has superior ganglion and inferior ganglion. At the level of inferior ganglion, outside jugular foramen, it divides into three. वन इट गिव्स ब्रांच टू फेरिंजियल प्लेक्सस, है ना. सो 9-10 मिला के बनाएंगे, सबको सप्लाई करेंगे. अब दो ब्रांचेस है मेन. वन इज योर सुपीरियर लैरिंजियल नर्व, विच, एक एक वर्ड ध्यान से सुनो. ओके, कुछ भी नहीं लिखना, कुछ भी नहीं सुनना, आई मीन कुछ भी नहीं बोलना. सो एट द लेवल ऑफ हायोइड इट डिवाइड्स इनटू टू. सुपीरियर लैरिंजियल, external laryngeal, internal laryngeal. The other branch is going to be recurrent laryngeal nerve, which has a different course on both sides. Right side pe it hooks around the subclavian and goes into tracheoesophageal groove. Left side pe it hooks under the arch of aorta and goes into tracheoesophageal groove, penetrates the thyrohyoid membrane and supplies the laryngeal cartilage. Why difference in right and left? Because of the sixth arch. Sixth arch से क्या arise करता है? PADA, pulmonary artery ductus arteriosus. So it's because of the sixth arch that they have a different course. Repeat question. Okay, तो ये हो गया course. Now, two thumb rules you understand. Vocal cord palsy becomes a cakewalk. It is so easy. So one rule: all the muscles are supplied by, all laryngeal muscles are supplied by recurrent laryngeal except cricothyroid, which is supplied by what? Superior laryngeal nerve. But what branch of superior laryngeal nerve? External. External laryngeal nerve or superior laryngeal nerve supplies cricothyroid. Isn't it going to be very easy? So the mnemonic is, ऐसे बोलते हैं ना, this is tad bit too easy. So tad is our mnemonic. So cricothyroid का function क्या है? It is a tensor and it is an adductor. Just hold this thought and we will get to it when we go to the function. अभी याद रखो, ELN cricothyroid, which is a TAD, which is a tensor and an adductor. So SLN के दो branch है, external, internal. Where was it dividing? Dividing at the level of hyoid, right? External laryngeal nerve. हम लोग बाहर से बहुत muscular है, but अंदर से we are all very mush, right? So muscular men who are very mush, very sensitive from inside. So just like that, external laryngeal nerve muscular. It is motor. किसको सप्लाई कर रहा है? अभी अभी देखा, क्रिकोथाइरॉइड को, टैड को. इंटरनल लैरिंजियल नर्व अंदर से वेरी सेंसिटिव, सेंसरी नर्व. किसको सप्लाई करेगा? सुपीरियर लैरिंजियल नर्व. सो अबव द वोकल कॉर्ड, sensory supply is by superior laryngeal nerve. Below the vocal cord, it is going to be by the only nerve which is left, recurrent laryngeal nerve. Okay, so this is how we have to remember functions, and now it's all about application. उससे पहले कुछ कुछ anatomy questions. Internal laryngeal nerve supplies cricothyroid. Internal? No, it was internal, अंदर से तो sensitive है, motor, right? So external laryngeal nerve. SLN arises at the level of hyoid. True or false? It divides at the level of hyoid, not arises. Arises to inferior level, inferior ganglion पे. RLN supplies all extrinsic muscles posterior. No, except cricothyroid. Correct. RLN enters larynx behind cricothyroid joint. This is true. है ना, पीछे से आती है. Aortic arch aneurysm can lead to right recurrent laryngeal nerve palsy. No, left side, right? Left में aortic arch पे वो अड़ेगा. ठीक है. So if you have understood this, you have understood the anatomy. Clear? अब इंजरी, बस खाली एप्लीकेशन. तो इंटरनल लैरिंजियल नर्व का फंक्शन क्या था? अंदर से वी आर ऑल वेरी सेंसिटिव. तो अगर सुप्राग्लॉटिस का सेंसेशन चला जाएगा तो क्या हो जाएगा? सेंसेशन ही नहीं रहेगा, यू विल एस्पिरेट, राइट? सो यू विल एस्पिरेट स्टफ हियर, सो दिस विल लीड टू एस्पिरेशन. एक्सटर्नल लैरिंजियल नर्व, इसका एक ही फंक्शन था, बाहर से मोटर, क्रिकोथाइरॉइड. अब क्रिकोथाइरॉइड का फंक्शन क्या है? टेंसर एंड अडक्टर, isn't it? So tensor. So let's see कि unilateral external laryngeal nerve है. So unilateral है, so what will happen is we can't tense the vocal cord, right? So we cannot modulate the pitch. जैसे मैं अभी कभी जोर से बोल रही हूँ, कभी कम बोल रही हूँ, pitch में problem होगा. Cannot modulate pitch. बाकी कोई issue नहीं है. Only one side basically adduction will not be there. Cord would be abducted. Doesn't make a difference. But when you have bilateral external laryngeal nerve, तो क्या हो जाएगा? दोनों ही adduction काम नहीं कर रहा. So what would happen? The cords are all abducted. राइट. सो कॉर्ड्स अगर अबडक्टेड रहेंगे तो क्या प्रॉब्लम है? एस्पिरेशन नहीं होगा. अगेन सेम थिंग, बेसिकली यू वोंट बी एबल टू स्पीक प्रॉपर्ली, राइट? सो वॉइस इश्यूज होंगे व्हेन यू हैव बायलेटरल अबडक्शन. बेसिकली पैरामीडियन पोजीशन हो जाएगा. सो हियर वी आर गोना हैव पैरामीडियन पोजीशन ऑफ द कॉर्ड. सो जस्ट रिमेंबर कि कॉर्ड्स कैसे होंगे, पैरामीडियन. ऑलराइट, सो दिस इज व्हाट यू नीड टू रिमेंबर अबाउट एक्सटर्नल. अब पूरी की पूरी गई, सो व्हाट वुड हैपन? पूरी की पूरी गई,
बाकी अडक्टर नहीं, बाकी सब अबडक्ट करके बैठे हैं ना, सो बाकी सब अबडक्ट करके बैठे, अडक्ट नहीं हो पा रहा, दैट इज द प्रॉब्लम। सो उससे भी खास कोई इश्यू नहीं हो रहा हमें इन द दिस थिंग। यहाँ पे क्या होगा, सो अगेन यू हैव एस्पिरेशन एंड यू हैव पिच इश्यूज, राइट। तो ये प्रॉब्लम है। अब जाते हैं रेकरेंट लैरिंजियल नर्व। सो रेकरेंट लैरिंजियल नर्व में क्या इश्यू हो रहा है, दैट नाउ ओनली द अडक्टर इज फंक्शनिंग। सो क्या हो जाएगा, अडक्ट हो जाएगा, बाकी सारे ही मसल्स गायब। So all the only the adductors are functioning. So what will happen? Cords are now in the median position, right? So median or paramedian position. All right. ये वाला भूल जाओ. So this is going to be in the medial thing. इसको भूल ही जाओ. Right. So this is going to be median or paramedian position. So what will happen? You will have strider. Right. So you're going to have strider. So what is going to be the next step? वो बताऊंगी cadaveric. No, not cadaveric. So this will be somewhere in the middle, basically. Yeah, so the next step, you always have to preserve the airway. You have to do a tracheostomy first, and later on you can plan a lateralization procedure, right? So lateralization, this will only happen if you have bilateral recurrent laryngeal nerve palsy, right? So two recurrent laryngeal nerve one, which type of thyroplasty is lateralization? Two. Okay, so type 2 is lateralization because we have bilateral, two recurrent laryngeal nerve need to go, तभी दोनों cords median आएंगे, isn't it? कंप्लीट हो गया, SLN भी गया और RLN भी गया। सो SLN अगर गया, व्हाट विल हैपन, एस्पिरेशन। व्हेन बोथ आर गॉन, ना कोई अबडक्टर है ना कोई अडक्टर है, विल वी बी इन कैडावरिक पोजिशन? यस। इफ यू आर इन कैडावरिक पोजिशन, स्ट्राइडर तो नहीं होगा, बट कैन वी स्पीक? We cannot speak. So now we will have two A's. When two nerves are gone, we have two A's: aspiration and aphonia. Okay. One more time, very quickly. Internal laryngeal, aspiration. External laryngeal, pitch issues. Superior laryngeal, both pitch as well as aspiration. Recurrent laryngeal nerve adduct हो गया because of overaction of fricothyroid. So stridor, very serious. Complete हो गया, very serious. Aspiration and can't talk. बोल भी नहीं सकता और aspiration भी कर लेगा. Right? So this is what we have. Yes, only if bilateral. All right. So just one more time. So whenever we have median paramedian, whenever recurrent laryngeal nerve palsy is going to be there, we will have adductor ka function. So I'm going to have either on the midline or I would have 1.5 mm ka gap. Cadaveric, when both the RLN and SLN go, this is going to be cadaveric position. Abduction is when you have paralysis of adductor. So जब ये वाला जा रहा था ना, so this is the position we will have, which is gentle abduction. So around 7 mm. That is what I was trying to say. कि बीच का position होएगा. अंडरस्टूड. सो दिस इज दैट इंपॉर्टेंट डिफिकल्ट टेबल. अब ये बताओ, अब लेट्स सॉल्व. ओके, हाँ, होर्सनेस होएगी, माइल्ड माइल्ड होर्सनेस. ओके, एस्पिरेशन विद यूफोनिया, 2A हो गया, मतलब टू नर्व्स, SLN और RLN. वेरी नाइस. फटाफट से क्लिनिकल केस सिनारियो में करते हैं. सो हियर यू गेट अ हिस्ट्री की फिश बोन अड़ गया है. इमेज बेस्ड क्वेश्चन, कहाँ पे अड़ा है? फर्स्ट ऑफ ऑल एरिटिनोइड के पीछे जब आता है, सो दिस इज piriform sinus, right? So these are a piriform sinus. Piriform sinus में कौन सी nerve associated होती है? So this is a applied anatomy question. So here you have the internal laryngeal nerve. So this bone can actually touch and affect the internal laryngeal nerve. So जब internal laryngeal nerve is sensation, so what will this patient have? Aspiration, right? So this is going to be aspiration. When we talk about skull based surgery की जब बात आएगी, remember we can have both the nerves which are affected, right? So SLN and RLN will get affected, and you can have what? You can have aspiration and aphonia. Two nerves, two ways. Thyroid surgery, most common nerve to be affected, superior laryngeal nerve or external laryngeal nerve. Very controversial, but any of these two. Okay, so when this is affected, अगर पूरी की पूरी गई तो एस्पिरेशन एंड यू विल हैव पिच इश्यूज. खाली एक्सटर्नल गई तो यू विल हैव ओनली पिच इश्यूज. ऑन द अदर हैंड, लुक एट दिस, यू हैव एन आर्च एन्यूरिज्म. एन्यूरिज्म फ्रॉम आर्च ऑफ एओर्टा क्या होगा? लेफ्ट रिकरेंट लैरिंजियल नर्व पॉलिसी. अगर खाली रिकरेंट लैरिंजियल नर्व पॉलिसी एक साइड की है, यू विल हैव माइल्ड होर्सनेस. बट अगर दोनों तरफ की रिकरेंट लैरिंजियल नर्व पॉलिसी हो गई तो क्या होगा? You will have stridor, isn't it? Median position पे आ जाएगा because of adductor. समझ में आ रहा है सबको? हाँ, रटना नहीं पड़ेगा ना बिल्कुल. वोकल कॉर्ड पॉलिसी एक बार समझ लिया फंक्शन. ओनली इफ दिस स्लाइड यू हैव डन, देन इट्स वेरी वेरी इजी. ठीक है, थायरोप्लास्टी कर लेते हैं. सो व्हेन यू हैड बाइलेटरल रिकरेंट लैरिंजियल नर्व पॉलिसी टाइप 2, which was what? दूर करना है. So this was lateralization. Okay, so this is thyroplasty. Apart from that, we can do something else also. What is this procedure called? जब हम लेजर से जला देते हैं दोनों को, this is called as Kashima's operation. ठीक है, तो how to remember this is, do you know बाजीराव मस्तानी? उसमें काशीबाई होती है, राइट? सो काशीबाई इज थ्रोन अवे बाय दीपिका पादुकोण. जब दीपिका पादुकोण आ जाती है तो काशीमा इज gone, lateral. ठीक है, so this is also lateralization, going away. Okay, so you can remember that way. The type 2 thyroplasty. On the other hand, type 1 must be what? Medialization. Okay, so this is medialization. 3 and 4. 3 में क्या हो रहा है? So this is used in puberophonia. So puberophonia is when you have a boy who has a very high pitched voice. लड़की जैसी high pitched voice है. तो what will we say? वो लड़का ना बहुत short है. Remember one short boy in your school who has very high pitched voice. So उसको हमें क्या करना है? We have to shorten. So short याद रखो. So we want to shorten the vocal cord. क्या हम उसको बोलेंगे? Chill मार, relax कर life में थोड़ा. Want to relax, right? So you want to relax the vocal cord. You want to shorten the vocal cord. That is the procedure that we are doing in type 3 thyroplasty, which is for puberophonia. Or we could do one maneuver also. जब दबा दो उसका vocal cord. What is that called? That is called Gutzman maneuver, right? So that is called as Gutzman's maneuver. Type 4 में क्या कर रहे हैं? It's उल्टा, एंड्रोफोनिया. So एक गर्ल है जिसका बहुत ही लो पिच्ड वॉइस है, जिसको आपको हाई पिच करना है. सो हियर यू डू द ऑपोजिट, यू वांट टू लेंथन इट. सो लेंथन कर दो वोकल कॉर्ड को, टाइट कर दो वोकल कॉर्ड को. ठीक है, थायरोप्लास्टी समझ में आ गई सबको? इजी. थोड़ा सा क्या करेंगे अब? थोड़ा सा एनाटॉमी कर ले लैरिंग्स का फटाफट से. व्हाट डू यू वांट टू डू? हाँ बस अब तो खास रह ही नहीं गया एक्चुअली, ओनली बहुत ही कम रह गया. सीए लैरिंग्स तो मैं कराऊंगी भी नहीं. ओके, सो सी दिस, व्हाट डू वी हैव हियर? सो सीटी का एनाटॉमी फटाफट करा देती हूँ. सो दिस इज द एपिग्लॉटिस. ओके, सो एपिग्लॉटिस से आगे जो आ रहा है, दिस इज योर प्री ग्लॉटिक स्पेस. जो ऊपर आ रहा है इससे, दिस इज कॉल्ड वैलिक्यूला, है ना? दिस इज कॉल्ड वैलिक्यूला. एंड जो उसके पैरेलल है, दैट इज योर पैराग्लॉटिक स्पेस. सो आई जस्ट वांट यू टू आइडेंटिफाई एपिग्लॉटिस. एपिग्लॉटिस के आगे प्री ग्लॉटिक स्पेस एंड दिस इज वैलिक्यूला. दिस इज अ सैजिटल सेक्शन. ओके, एक्सियल सेक्शन पे कैसे? तो सबसे पहले इसका इमेज बताओ, लैरिंगोस्कोपी का इमेज. कैन यू आइडेंटिफाई दिस? सो दिस इज द एपिग्लॉटिस. ठीक है, तो ये एंटीरियर है. सो फ्री सरफेस ऑफ एपिग्लॉटिस हो गया. दीज आर योर ट्रू एंड फॉल्स वोकल कॉर्ड्स. पीछे क्या है? एरी एपिग्लैटिक फोल्ड्स. एंड उसके पीछे क्या है? पिरिफॉर्म साइनस एंड पोस्टीरियर क्रिकॉइड स्पेस. Yes, same thing on CT now they ask you. Last year INI CT they asked you same in CT. So can you imagine this is the free edge of epiglottis? दोनों को कोरिलेट करो तो मजा आएगा. So this is called as free edge of epiglottis. तो ये क्या हो गया? प्रीग्लॉटिक स्पेस. ये कैसी हो गई? पैराग्लॉटिक स्पेस. अंडरस्टूड? और ये दो पाउच कौन से हो गए जो हमने ऊपर भी देखे थे? These are your, so what are these? यहाँ पे जो आ रहे हैं, right? So these are your piriform sinuses. Understood? So basically same thing. Are you trying to are you getting this image? So epiglottis, preglottic, paraglottic space, and these pouches are your piriform sinus on the CT. उससे थोड़ा सा नीचे जाएंगे because we are taking axial cuts, right? So जब ऊपर कट लिया तो I am seeing piriform sinus, I am seeing epiglottis. When I go down, I'm going to see the vocal cords. So these are your vocal cords here. ठीक है, so these are your false vocal cords here. And what is this cartilage? This is your thyroid cartilage, and this is where you have the arytenoids which come in. So these are your arytenoids marked by the arrow, and this is your thyroid cartilage, okay, which is white. So it calcifies with age, right? So this is your calcified thyroid and this is your arytenoid. Okay, so this is how you want to identify the anatomy. So this is epiglottis, this is preglottic space, this is paraglottic space, and पीछे जो sinuses है, these are your piriform sinuses. Okay, got it? फटाफट से larynx की image. Why not see a larynx? Because I've covered it. वो homework में दे दूंगी. I'll tell you where to read it from. Okay, quickly बताओ ये क्या है? Whenever you see these papillomas, this is your laryngeal papillomatosis. Okay, so this is multifocal. So this is juvenile papillomatosis. Okay, treatment is going to be via laser, CO2 laser. And is this hereditary? हेरिडिटरी नहीं है, बट मदर के केनाल में जो पैपिलोमा वायरस थे उससे हुआ है. सो मदर मस्ट बी हैविंग व्हाट? कोंडाइलोमा अक्यूमिनाटा. सो विच HPV वायरस? 6 and 11. 11 is more common than 6. But 6 का फायदा ये है that this occurs at 4 to 6 years. 4 to 6 years of age पे ये करना है. Cidofovir is not indicated here. Cidofovir is indicated when you have an isolated papilloma, only when single papilloma, not for recurrent respiratory papillomatosis. Okay, so this is CO2 laser. Will you remember this, everybody? Okay, what is this? Very irregular sort of a larynx. Yeah, so this is your turban larynx. TNB नाम में ही है. This is TB. This can also have a rat bitten or a mouse bitten appearance. ठीक है, 4 to 6 years में प्रेजेंट करेगा बच्चा, मेल या फीमेल जो भी है प्रेजेंट करेगा. ओके, सो दिस इज माउस बिटन और टर्बन लैरिंग्स इन टीबी. पेन होएगा नहीं होएगा? पेनलेस, पेन नहीं होता इसको. ठीक है, वो एक एमसीक्यू है, रिपीट, पेन नहीं होता. ये क्या है? सबसे पहले अनाटमी बताओ. तो ये क्या हो गया? ये हमारा फ्री एज ऑफ एपिग्लॉटिस हो गया, राइट? एंड ये हमारे सॉरी, ये अरी एपिग्लॉटिक फोल्ड हो गया, and ये piriform sinus हो गया, isn't it? So this is basically your vocal cord. When you see bilateral, so these are your teacher or singer nodules which are seen. जब unilateral आता है, जब यूनिलैटरल है, दैट इज कॉल्ड एज पॉलिप, राइट? सो दैट इज कॉल्ड एज पॉलिप. दोनों में ही मैनेजमेंट क्या है? दोनों में ही मैनेजमेंट इज वॉइस रेस्ट, राइट? वॉइस रेस्ट करना है. पॉलिप कैन बी रिमूव्ड आल्सो. माइक्रोलैरिंजियल सर्जरी से पॉलिप कैन बी रिमूव्ड. सो इट इज एज अ जंक्शन ऑफ एंटीरियर 1/3 एंड पोस्टीरियर 2/3, ऐसा करके. ठीक है, व्हाट इज दिस? वेर इट्स वेरी वेरी इरेगुलर. सो दिस इज ऑब्वियसली सीए लैरिंग्स. व्हेन यू सी इडीमा, लैरिंग्स का इडीमा आ गया डिफ्यूज, इसको क्या बोलते हैं? This is called as Ranke's edema. ठीक है, तो Quincke's और Quincy से confuse नहीं करना. This is Ranke's edema associated with smokers, GERD, myxedema. These are the other risk factors. ठीक है, smoker, myxedema, GERD. On the other hand, सबसे favorite question, omega shaped epiglottitis is going to be seen in laryngomalacia. तो कैसे बच्चा आएगा आपके पास? Cry would be normal or abnormal? Cry would be normal, but बच्चे को क्या होगा? You will have inspiratory stridor. ठीक है, तो जब भी रोएगा तो इंस्पिरेटरी स्ट्राइडर हो जाता है. बट क्या करने पे ठीक हो जाएगा? व्हेन यू प्लेस द बेबी इन प्रोन पोजीशन, इट इज रिलीव्ड. डू वी वांट टू डू एनीथिंग? कुछ नहीं, बोलो चिल मार बच्चा, 2 साल पे आना, ठीक हो जाएगा, राइट? सो बाय 2 years they will resolve on their own. So this is omega shaped laryngomalacia. Very very important question. What is this? This is the Cotton-Mayer grading of subglottic stenosis. Subglottic stenosis, remember these are the grades. And what else do we want to remember here? इसको treat कैसे करेंगे? You want to do a surgery here, and after surgery you want to put mitomycin. Remember, mitomycin खाली treatment नहीं है, just because it's a repeat question. Mitomycin is used to prevent recurrence. Okay, so it is not the treatment. To reduce the recurrence, we are putting mitomycin. Surgery is the treatment. Okay, हाँ बाकी चीजें डाल दो, Calistic keel and all, but mainstay is this. Okay, so this is about Cotton-Mayer grades. 2 mirrors, फटाफट से last thing. So जो सीधा है, this is indirect laryngoscopy, IL, और जो टेढ़ा मेरा जा रहा है, so P and R are both टेढ़ा. Look at R, very very टेढ़ा letter, right? So this is PR, है ना? ये गलत होता है ना, इसीलिए मैंने लाया. So this सीधा is IL and जो उल्टा फुल्टा है is posterior rhinoscopy mirror. ये चीज आप खुद पढ़ लो कि structures which are not visible. And बाकी आपका homework है CA larynx. I will give you the slide number, I mean the link, and that you have to revise. Okay, so ENT is almost complete. I could not have done more than this in 3 hours. Okay, we have done almost everything that ENT has. तो बस ये रिवाइज करना है. बाकी MCQs आपको MCQs का देखते हैं. What I will do is we'll do this स्पेशल क्लास. स्पेशल क्लास में सारे MCQs रिवाइज कर लेंगे. हाँ, ओनली CA larynx and then miscellaneous में जो चीजें हैं उनका मैं लिंक दे दूंगी. ENT RR का फटाफट से I will just tell you the link, or we'll do this in some doubt solving sessions. Okay, vocal cord position I explained, no Divya? I already explained. ये बता दो चलो, ये सारा ही एक doubt solving में करा दूंगी. Okay, so just your homework is only CA larynx. Everything else I will cover for you. Mostly everything is done. Just these 2-3 foreign body things which are very non-specific we will do. Okay, all right. So thank you so much. Tomorrow, yeah. So tomorrow we have 2 classes, guys. So FMT will finish tomorrow only. कल खत्म कर देंगे. हाँ, PEDS and ENT everything will do as MCQ. So I'll tell you the plan. Just hold on. तो कल का plan है 3 PM and 6 PM. 2 FMT sessions. तो कल FMT खत्म हो जाएगा. उसके बाद 30th को we will have 2 classes, 7 p.m. and 10 p.m. 7 p.m. is going to be radio quiz and 10 p.m. is going to be a quiz of all of these subjects. So what we'll do is we'll do PYQs of FMT, ENT and PEDS and some new questions of Derma. ठीक है, तो ये सारा कर लेंगे. Let me see. Okay, I'll send you the link of CA larynx. More में नहीं है, but there was this BTR session where I have covered. Okay, ज़ारा का eating time है, इसलिए वो busy रहती है actually. Just seeing if she can come. What Zara? Just hold. She's eating. She's having a dinner, and Ravi is not picking up. Can you just wait? I'll go and bring her only. And I just wait.